that I used in this presentation is adapted from the World Council for Optometry Myopia Management website. So I need to ask this question, and I always ask it all the time, why I need to worry about myopia in children. As Boris said, it's a good chance for us optoms to serve humanity and the future of humanity, since children today will be adults tomorrow. And if you think about it as emetropia being the odds ratio or the risk of one, let's say, if you have a myope between -1 and -3, their chances of developing a cataract or glaucoma or myopic maculopathy will be twice that of that emetrope. If we move to the myopia between -3 and -6, the chances will increase much, much higher, especially in the retinal detachment region. And if we think about the -6 and above, the high myopes, the chances are astronomical. Can you imagine 41 times bigger chance of developing myopic maculopathy compared to an emetrope? What future are we setting our children for if they develop very high myopia? Hence, this is the reason for all our work in myopia is to manage it. I like the word control. Management is a better word used, especially it was adopted by the International Myopia Institute and all the other um, bodies, let's say, that are dealing with myopia at the moment. So please, I want you to consider these numbers carefully when you ever see a child at risk of developing myopia. Okay? So the question is, can we do anything to mitigate the development? And here I chose this photo of an empty playground. I took it actually before the start of the when the pandemic of COVID-19 started and there were like no children there. It's usually filled with children during the week, and it saddened me quite a lot to see all the children confined in their rooms using their digital devices to study and not playing outside. And this is what we really want to consider when we deal with children. So, outdoor time is very important. And the concept of playing outdoor and enjoying outdoor time is literally as old as time, as they say. So, Harman in 1916, that's almost 100 years ago, I quote this from him. He said, "A robust child enjoying a maximum of outdoor life is less likely to get tired eyes and subsequent stretching of the coats of the eyeball." What Harman meant that if children play outdoor, they will not probably accommodate that much, and their axial length or their eye won't elongate as much as it will happen, and they will have less myopia compared to a child staying indoors all day, sitting over lessons, and never joining in vigorous outdoor games. Harman explained things that are happening currently in the 21st century, and this is a very important thing for us. One of the roles of optoms is to make parents aware of what's going on and advocate for outdoor play. So this is one of the things we need to work on. Some data from studies that actually prove what is going on. So basically, most of them are based in China, Taiwan, and Southeast Asian countries. And it shows that if you offered the children the option of having a recess between the classes, playing outdoor on each school day of at least 20 to 40 minutes, let's say, and compare them with children that they never had a recess. Uh, and in 1 year or 3 years' time, the progression of myopia will be less in children who had a chance to play outdoors and have breaks and what we call them recess, compared to children who stayed indoor and they didn't enjoy a little bit of sunshine. So these studies are quite good in terms of that myopia helps in delaying the onset. Sorry, playing outdoor helps in delaying the onset of myopia, and this is quite important for us to understand. The problem is once myopia is there, outdoor time doesn't play a big role in managing things. Okay? The evidence for, as I said, being protective against myopia progression is actually, unfortunately, quite mixed. We see seasonal trends in myopia progression. Where, for example, during summer months, where at least in the Northern Hemisphere, where students take at least a 1 month or 2 months break from school, the progression of myopia is less compared to the winter months where they have school time, where the progression of myopia increases. So this is quite interesting. However, the the studies are there, but the evidence is not as strong as we want it to be in terms of managing the progression compared to delaying the onset. So this is something we need to understand very carefully. So try from as early as possible to advocate for outdoor times, at least 14 hours per week, if possible. Okay. So again, this is one of the slides that I thought I would share with you. Summer myopia progression is less compared to winter myopia progression, as we said. So the studies vary from 30% less to 70% less. So really, we can't rely on all these data, but the general trend is improved outdoor time may play a role, improved light levels, less near work, less strain on the system of the eye, increased dopamine levels. We're not quite sure yet, but there is uh, an evidence for seasonal fluctuation, as they say. So, what is the main aim of this presentation is the mitigation and the measurement. The mitigation will be to identify those pre-myopes, try to ensure that you work with them as early as possible so that they won't you delay the onset of myopia. And if you have myopes, to manage the progression, to minimize it to the minimum if possible. And we're going to talk, the other part will be about how to introduce the measurements of myopia within your practice. So the first step is to identify those pre-myopes. So if you have one parent, this will increase the risk of myopia development by 3 times. Okay? Having two myopic parents will double those 3 times again. So it's very important to ask to have a good family history. Okay. I've seen so many optoms and so many optical practice literally ignore family history. So we need to think about this carefully. Also, we need to identify your case history by starting asking about the visual environment. Just ask how many hours or how many minutes the child plays outdoor or studies or stays indoor. Because science has shown us that less than 90 minutes a day spent outdoors increases the risk, especially, and this is very important, if it's combined with more than 3 hours a day spent on near work activities. Of course, outside the schooling time. Remember, our children, once they don't just spend time indoors having near work activity just to do the school homework. They're using their tablets for watching videos and playing games and everything. So we need to be careful with that. Another thing, and I remember the basic course, we had Fahima who taught with us about binocular vision, and evidence shows that children with higher ACA ratios, or those children, they are typically seen with esophoria, have an increased risk of developing myopia within 1 year around 20 times. So this is quite important. Also, Accommodative lag may also be a risk, and intermittent exotropia has also been associated with the onset of myopia. Again, my observations with optoms in optometry practices in the UAE, and I was in Oman a couple of days ago, and I've been observing them. We really tend to forget to include binocular vision assessment within our standard optometry practice. So, if you want to start working in myopia management with children, you need to brush up your skills on BV. Okay? I know you might want to send those children to an orthoptist, but unfortunately, not everyone has the luxury of having an orthoptist in their country or having them accessible. So you need to work on your BV skills. All right. You need to also identify the current refraction. You need to brush up on your refraction skills with PEDS. And the most significant risk factor, okay, if, and this is, please, I need you to focus on this. If a child exhibits half a diopter or less of manifest hyperopia between the age 6 or 7. So if you see less than or half a diopter or less than hyperopia in a 6-year-old child, this should be your biggest alarm because it's the most significant risk factor for future myopia in any child. Okay? And this risk factor is actually independent of any family history and visual environment. So we need to pay close attention. Unfortunately, many of us tend not to send their children to an ophthalmologist or an optometrist when they start school by the age of 6. And many countries do not have a school eye health program to screen children. And even if we screen children in schools, we usually tend to miss hyperopes anyway. It's not quite easy. So we really need to advocate for a robust assessment program for children to ensure that we catch them as early as possible. Okay. And I need you to understand something. If you are following up a child, you will notice that the fastest rate of refractive change occurs in myopic children, actually occurs in the year prior to the onset of myopia. So the child who is less hyperopic than the age normal should be closely monitored, especially if there are other concurrent factors, because we want to ensure that the change in the refractive error is not as quick as in this case, and this will indicate that myopia probably will occur within a year. So this is quite important for you to understand. And this also spotlight the need for follow-up. Sadly, as parents, I am a parent, and I do not comply with the instructions of my doctor or my children's doctor all the time. Sometimes I switch from one doctor to another, and this is not good. You need to have a consistent pattern with the optometrist or the ophthalmologist who are working with the children, and you need to comply with all those follow-ups. Okay. The other point is to identify the myopia progressor. So we have the pre-myopes, and we have the already, if you know there's a myopic child, you will go to the other category of the myopia progressor. Okay. And the thing is, age is an important factor. The younger a child becomes myopic, the faster they will progress. Okay. If myopia occurs in a 5-year-old child, they will develop at least one diopter of myopia per year. However, if they develop myopia later in life, it will be half of that if it happens by the age of 11 or 12. So can you imagine just 3, 4 years difference make a huge difference in terms of the myopia progression? Okay. Again, family history. Children with two myopic parents have been shown to be the fastest progressors if they are wearing single vision specs. Okay. So you need to ensure that you have good family history so that you will monitor closely those myopia progressors. Again, your work is quite important. So if you uh, spend your time working at near for distances less than 20 centimeters and the durations of longer than 45 minutes, this is or has been shown to be linked with more myopia progression. So you need to, when you have a myopic child, you need to work with the parents and the child to ensure that they have good visual hygiene in terms of the working distance and ensure they have breaks when they are doing their near work and try to minimize the near work as much as possible. Okay? Next. All right. Ethnicity, of course, Asian ethnicity has been linked to faster myopia progression. So if you are working in Dubai or Abu Dhabi, for example, you have patients from all ethnicities and nationalities. So you need to really ask about ethnicity when it comes to myopia and children. Of course, BV, we talked about that. Children with esophoria are found to progress more quickly compared to other children, and children also with a larger baseline accommodative lag show statistically greater treatment effect. So you need to understand and work with these children. Okay. Children actually who have a lower accommodative amplitude has shown to have greater myopia management response with ortho-K. So this is something we need to consider. All right. Good. I would also like to categorize the children in this age under 8 and refraction of at least 0.75. So if the children have an age normal amount of hyperopia, which should be at least 0.75 plus, they will be at much less risk of progressing to myopia compared to children who have their eyes growing too quickly towards emetropia. Of course, our end goal for any child is to have emetropia, okay? But the emetropization process, if it's too quickly compared to age norms, then I will be worried because the child might be at risk of developing myopia, okay? And all those other things like parental myopia, low outdoor time, and everything will add to the issue and should be checked carefully. Hence, the need for that annual eye exam, which many of us are sadly missing. Okay. And of course, if you have a child who is under the age of 8 and having a good normal age refraction of 0.75 or more, what you can do basically is to advise them on visual hygiene in terms of visual environment, less screen time, more outdoor time. This is the only thing you can do. Some people ask me, should I be proactive in terms of myopia management and start introducing those myopia management lenses even if there wasn't myopia? The question is, you need to be careful. If you see that type of children, the only thing you should do is to manage the environment, and that's it. Okay. So another thing is we need to listen to WHO sometimes, not all the times, of course. And their screen time guidelines recommend that children aged 5 to 17, this is a wide age group, by the way, should have no more than 2 hours of recreational time screen time per day and only 1 hour per day for preschool age children. So if we have children who are at the preschool age, shouldn't spend more than an hour on screen time for recreational purposes. And children who are in the school age should only spend maximum 2 hours per day. So this is quite important. And I've seen with the updates in softwares with digital devices, they also actually tell you the amount of time and the distance that you are working with the screen, and they are warning you. So I think this is something very important for us to consider. Okay. So encourage all children to put down their screens and get out and about if possible. So another group now we'll move to is children who are under the age of 8 and have less than 0.75 diopter of hyperopia. Remember, the strongest predictor for future myopia is any refraction less than plus 0.75 at this early age. Remember the clear study that we discussed in the basic course? And they found out that future myopia by the age of 13, let's say, is highly likely will be in children who had less than plus 0.75 by the age 6 and 7 or 7. Okay, we need to watch these children carefully, manage their visual environment rigorously, and they need to have not just yearly eye exams, if even at 6 months interval if possible. So those children who are under the age of 8 and having hyperopia less than plus 0.75, they need to have close observation, and you need to plot their growth chart in terms of the refraction growth and the axial length growth to compare it with age norms. Now you will ask me, do we have age norms for Middle Eastern children? Sadly, we don't. But our European colleagues have done some age norm data plots. And let's say if we compare the prevalence of myopia in children between Middle Eastern populations and European populations, the prevalence is very similar. Even the genes, I was just giving a lecture an hour ago on the genetics in myopia, and the myopia loci are quite evenly distributed between Caucasians, Europeans, and the Middle Eastern population. So look at the growth charts in European studies. They can give you a guide if you are working with Middle Eastern children. Okay. Another group that we need to look at, and this is the way I thought I should maybe help you in dividing your patients so that each category you can focus on differently. This category will be children under the age of 12, and they have an axial length growth of 0.1 millimeter per year. So remember, we talked about the emmetropization. The hyperopia will become less, and the eyes will expand a little bit, and we'll reach that balance between the flattening of the crystalline lens, the growth of axial length, to give us what eventually emmetropia. Again, the clear study, um, they've done an 11-year period longitudinal study. They found out that axial length in children who remained emmetropic was steady from ages 6 through their teens, around 15, at approximately 0.1 millimeter per year. So if you have a child who only progresses by zero point 0.1 millimeter per year, and they have age matched refractive error, you will feel comfortable in working with them. You will uh, probably not expect for them to have myopia, but what you can do is to observe them closely, ensure good visual hygiene, which is anyway useful for our children. Okay. Your other category that you need to work with, I know how many times, how many minutes? I only have 6 minutes, but I think, Swarna, can I extend my talk by another 5 if possible?
Yeah, sure. No problem, Dr. Azam.
Thank, thank you, sir. Thank you. So, another category of children you need to work with are emmetropic children who have a family history of myopia. So, Remember, we talked about one child, one myopic parent having 3 times the risk, two myopic parents having 6 times the risk. So this is something we need to consider. Having siblings, brothers and sisters who are already myopic, increases the child's chance of developing myopia independently to their parental myopia. Okay, so you also need to ask about the siblings' uh, history in terms of having myopia or not. This is quite important. Okay, so if you have an ametropic child who has parents or siblings who are myopic, you need to monitor them closely and plot these growth charts as early as possible to ensure they're not deviating towards that myopia risk stage. Okay, so now if you had a child who is already myopic, you need to plot, of course, their growth charts and charts. And remember, if in these cases, the fastest axial growth, remember, as we said, occurred usually in the year before the myopia onset, usually zero point millimeter or more growth per year. Okay? Before that year of onset, they will usually have at least 0.3 millimeter growth. So you need to monitor these children carefully. And remember, I love this motto, Every Diopter Matters by Mark Willimore, and I usually advocate for it all the time since there is no safe level of myopia, as we've seen in the first slide. So we need to be proactive in managing the myopia immediately with these groups, okay? So how much axial growth is normal? Just to remind ourselves, okay? The children between ages 7 to 10, emmetropes usually have around 0.1 millimeter per year axial elongation. Okay, maximum to 0.2. Between the ages of 11 to 16, usually you will not have more than 0.1 millimeter, and the elongation will cease by their teens. Okay, so you need to remember these numbers quite importantly. Remember the 6 and 10 rules we talked about in the basic level? This shows us that it's very important to assess children by the age of 6, and there's a shift happening in the elongation of the eye after the age of 10. So you need to monitor these two groups separately very closely. Okay? So again, what happens in myopes? They will have a greater axial elongation. Okay? In younger children, 0.3 millimeter usually. In older children, usually 0.2, 0.2. So that's very important. In Asian ethnicities, actually, they will have more than 0.3 millimeter. Those numbers, 0.2, 0.3, are usually with Caucasian European ethnicities. Okay? And this is quite interesting. Companies are now looking at the science in terms of designing their lenses, okay? And they are recognizing that younger children need a different design compared to older children, okay? So we talked about case history, and this is quite important. In terms of your refraction, the International Myopia Institute doesn't say which preferred method of refraction you need to adopt, but of course, retinoscopy is a very important tool. Now, you need to ask me, should we use cycloplegia? Yes. However, when indicated, because the myopia definition by the IMI, which has been adopted globally, says myopia is less than 0.5 diopter, blah, 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 when ocular accommodation is relaxed. Okay? So that term will avoid literally the term cycloplegia, but it tells us that you need to relax accommodation. Okay? There are several techniques to relax accommodation. We are doing your refraction. So cycloplegia shouldn't be a hurdle, but it's very recommended when indicated. Okay. BV. Unfortunately, there is no gold standard binocular vision assessment process. However, we need to assess amplitude of accommodation, accommodation of convergence association ACA ratio, check for phoreas, and this will be the important things for you to do, guys. Okay. Anterior segment, every time they ask me, should I do slit lamp anterior segment examination? As a standard practice for every patient as an optom, yes, it is your duty. Okay. But it will be even more important when you want to fit contact lenses because you want to ensure healthy cornea, healthy conjunctiva, healthy anterior segment, and you need to monitor any side effects for those. Okay. So you need to ensure that you are complying with clinical care pathways anyway in your country. So in summary, there is enough evidence to tell us that if we let children play outdoors in their young age, it will help in delaying the onset of myopia. Sadly, there isn't a robust evidence for managing the progression uh, with outdoor play once myopia onset happens. That's why we created those patients categories. So any patient who has more than 0.75 diopter before by the age of 6 or before that, we need to monitor closely. Any child who has parents who are myopic or siblings who are myopic, we need to monitor them closely. If there is less hyperopia compared to the age norms, by the age 6, 7, we need to definitely monitor them closely. Once they have the myopia, you need to manage it as quickly as possible. You need to be proactive. Okay. Of course, you'll ask me, well, we don't have all the equipment. The idea is you need to develop your clinical competencies and create pathways, co-management, shared care schemes with ophthalmologists and with your colleagues and within the professional standards in your region. If, for example, if I'm now in the UK where I studied, I would definitely do cycloplegia on every single child. When I'm here, if I'm working in the hospital, I will do that. If I'm working in high practice and I'm not allowed to use cyclo, then I can use other methodology, or actually I can refer that patient, get that cyclo refraction and start working with them. Okay. In terms of axial length measurement, it's quite crucial to do it every year. Very few practices have it, so you need to collaborate with your colleagues. And remember that every diopter matters in terms of managing myopia. So we need to stay up to date, hence those series of webinars. And by that, these are my references. And thank you so much.
Thank you so much, Dr. Yazan, for sharing your knowledge and thoughts on myopia management. Friends, requesting you to kindly put up your questions, if any, in the chat box, which we can discuss during panel discussion.
Good evening, everyone. Really happy to see the high level of this second episode. I'm really happy to be doing this collaboration about myopia management. Thank you very much, Dr. Yazan. Thank you, UEF, everyone here. I am going to share with you the presentation of Padma. I don't know if you know her, but she's one of the master in terms of myopia management right now. She has been enrolled by ZEISS for now, and I'm really happy to welcome her Not directly, but she took the time.
Hello, everyone. My name is Padmaja Sankaridurg, and
I'm
I'm the
sorry.
head for Global Myopia Management.
Yeah, I'm just trying to put. Can you see my screen? Yeah?
Yes, it's visible.
Yeah, it's visible. Okay. Because I just cannot. I'm just going to stop. Okay. Now it's working. Hopefully. I think I need to stop and do it again. Okay.
Hello, everyone. My name is Padmaja Sankaridurg, and I'm the head for Global Myopia Management at ZEISS Vision Care, as well as a conjoint professor at the School of Optometry and Vision Science, University of New South Wales.
I don't know what you see. My screen is freezing, but I believe you can see it.
And continue from here also, no problem.
Okay.
Now, by now, most of you probably already heard that in the year 2050, it is estimated that nearly half of the world's population will be myopic. But if you look at this data closely, what you see is that in the year 2020, approximately 1 out of 20 individuals were highly myopic. By the year 2050, it is estimated that this will rise to affect 1 out of 10 individuals with high myopia. In other The impact of this rising prevalence as well as rising severity of myopia is quite substantial. But there is now much evidence that indicates that we can reduce the burden by changing the trajectory. And we can do that by trying to prevent the onset of myopia and in individuals that are already myopic by slowing the progression of myopia. Now, we do know that the greatest return on investment is by trying to delay or prevent the onset of myopia. But at this point of time, we can do that only with limited means, such as trying to improve time modos. In those that are already myopic, there are a range of options that are available to the practitioner at the present time. These range from spectacle lenses to contact lenses to pharmaceutical strategies such as low-dose atropine. Specifically, if we talk about spectacle lenses, we all know that they're a convenient option, generally economical, as well as the first go-to options, especially in young children with myopia. So with that, if we take a look at the spectacle-based options that are available for us, what I have here is the numerous options that are currently available in the global market. Not all of them might be available in a given region, but generally, if we canvas and look at all the options, these are the sort of options that we have available. What we have here are what I refer to as first generation spectacle lenses. That's in the section to your left. These include executive bifocals and progressive addition lenses. These lenses, they generally comprise of two segments. The top portion of the lens is devoted to correcting the distance refractive error of the eye, and at the bottom or the near portion, there is a relative plus or an add power that is set to reduce accommodative lag. When we look at the more recent generation spectacle lenses, these lenses, they all comprise a clear central zone that corrects for the distance refractive error. And in the periphery, there is the treatment zone. The treatment zone is commonly relatively more positive than the central zone, or it has an add power, or in the case of some lenses, such as the dot lenses from side glass, there are these scattered dots. Now, the positive power, the relatively positive power, can be continuous in power profile, and it is said to reduce hyperopic defocus at the peripheral retina. And one such example is MyoVision from ZEISS. Or the positive power can take the form of lenslets or multiple segments, round circular segments, such as what we see with respect to MyoSmart or Stellus lenses from Essilor. And I've already spoken about the scattered dots with side glass lenses. Here, the hypothesis is that they modulate contrast at the retina. And with ZEISS Myocare, what we have are concentric annular elements that are said to impose simultaneous defocus at the retina and therefore slow. Now, one of the questions that come to mind when we look at these lenses is as to what portion of the surface area should be devoted to these elements, annular elements or segments. Here's an experiment that was conducted from Professor Earl Smith's lab from Houston. And what you see in this gray zone is what happens when the eye normally emmetropizes. It reduces in hyperopia and it achieves a certain level of refractive error. Now, if this eye is fitted with the full field biopic defocus plus 3 diopters, what you see is that the eye tends to remain hyperopic. And then if you fit that eye with the lens which has got these annular elements and you vary the surface power of these annular elements from about 50% to 18%, what you see is that despite the surface area being reduced, the eye still continues to become hyperopic. In other words, you can try and vary the proportion of the area that is allotted to these elements without losing efficacy. With that, I wanted to introduce you a little to ZEISS Myocare lenses. In these lenses, there are 3 considerations. One is the size of the central zone that is devoted for the distance refractive error, the power of these cylindrical annular elements, and the surface area, or the fill factor, in terms of what percentage of the area is devoted to these elements. Now we have 2 designs. The Myocare, it has got a smaller clear central zone, and the mean surface power of these annular elements is plus 4.6 diopters, and 50% of the treatment zone is devoted to these elements. In comparison, when we look at Myocare S, the central zone is slightly larger, the mean surface power is slightly lower, but the fill factor remains the same. In addition to these annular elements, the back surface of the lens is also optimized to try and reduce hyperopic defocus. So basically, along the back surface, there is point-to-point optimization so that we reduce the peripheral hyperopic defocus and therefore again try and slow the progression of myopia. Now, what is happening is that these lenses are in clinical trials across the globe. There's more than 1,000 children enrolled in these trials for us to be able to have information on the efficacy of these lenses. What we have is a single center trial that is ongoing at Wenjiao Medical University. And then we have 2 multi-center trials, one trial again in China across 3 different sites, and a trial that is being conducted in Europe. And in addition, there is also a trial that is again being conducted in China that we refer to as real-world evidence. And it is hoped that these trials will give us information about efficacy, long-term efficacy, as well as information on whether how these lenses perform across different ethnic populations, Asian and Caucasian eyes. Now, at the present time, we have information only from the single center trial, and that's 12-month data. And what we have looked at is the efficacy of the Myocare lenses when they're benchmarked against the progression that we see in a normal emmetropic eye. To explain this in brief, what you see on this graph is the annual progression that you see in a myopic eye. That's the red line. And you see that the younger children progress much faster in comparison to the older children. We also see that a normal emmetropic eye also continues to progress. And the objective of myopia management here is to try and slow the progression of myopia so that we reduce the eye growth and align it closer to that of what we would see in an emmetropic eye. With that, if we now look at what's happening with Myocare lenses, what you see is that there is substantial slowing of eye growth from that of a myopic eye, and it's much closer to that of an emmetropic eye. With Myocare, there seems to be this reduction across the ages, much more in the younger ages, whereas with Myocare Soft, the difference is much more in the older children. Now, when we look at Myocare, what we see is that it is 63% on an average, closer to that of the rate of eye growth that you would see in a normal emmetropic eye. And with Myocare Soft, it is 86% closer to that of eye growth that you would see in a normal emmetropic eye. Now, we spoke about lens design, and what I wanted to do for the next few minutes is to talk specifically about measurement and evaluation. That's number 2 of this 1 to 5 step guide that we talk about when trying to manage a child with myopia, and also talk a little bit about step number 5, which is monitoring. With respect to measurement and evaluation, and I specifically wanted to touch upon this because there are a number of questions that get asked about what sort of measurements we should do. In young children, cycloplegic refraction is quite important. That's because if we look at the difference between cycloplegic and non-cycloplegic measurements, especially in young children and in those where the refractive error is in the range of low myopia or emmetropia or hyperopia, the difference between your cycloplegic and non-cycloplegic refraction can be as much as 3/4 of a diopter. Or in other words, there is a chance that you can misclassify an eye as being myopic when it is really not myopic. You can do a check if you get such values to, if the eye is myopic, you would expect that there will be a decrement or a decrease in visual acuity. And if the eye does not have any decrease in visual acuity, but you're reading significant myopia, then it is all the more important that you go and do a cycloplegic measurement. In addition, we also get asked as to whether axial length measurement is necessary. You can by all means practice myopia management without axial length measurements. Axial length measurements are useful, especially when it comes to monitoring a progression of myopia, because the measurement is more accurate. However, you can still practice myopia management looking at the spherical equivalent refractive error if you do not have Now, just looking at adaptation and variability of these myopia management spectacle lenses, generally the data says that
I'm sorry. I just would like to be sure that we are not missing a good part here.
of these myopia management spectacles.
Mm.
Or in other words, there is a chance that you can misclassify an eye as being myopic when it is really not myopic. You can do a check if you get such values to, if the eye is myopic, you would expect that there will be a decrement or a decrease in visual acuity. And if the eye does not have any decrease in visual acuity, but you're reading significant myopia, then it is all the more important that you go and do a cycloplegic measurement. In addition, we also get asked as to whether axial length measurement is necessary. You can by all means practice myopia management without axial length measurements. Axial length measurements are useful, especially when it comes to monitoring a progression of myopia, because the measurement is more accurate. However, you can still practice myopia management looking at the spherical equivalent refractive error if you do not have access to a biometer. Now, just looking at adaptation and variability of these myopia management spectacle lenses, generally it says that children are able to adapt to these lenses and are able to wear these lenses for a significant amount of time. Here we've got some data with respect to ZEISS Myocare lenses, and you can see that 100% of the children said that they adapted to these lenses within a day. And when you ask them to rate their vision for various distances, as well as when doing various activities, on a scale of 1 to 4, where 4 is very good, you can see that most of them are saying that the vision is fairly normal or good with these lenses. Now, there's been a number of studies, research studies, that have looked at these measurements in detail. And what they show is that when the children are looking through the clear aperture of this myopia management lens, there is no change in visual function, be it visual acuity or you're looking at stereopsis and so on. When they look through the treatment portion, and here again, depending on the type of the lens, there could be a loss of visual acuity of a few letters to less than one line. And there is, it has been said that there is some loss of contrast sensitivity for certain higher spatial frequencies when children are looking specifically through that treatment zone. And the impact of these treatment zones on peripheral visual acuity and other tasks has also been explored. And again, it is seen that there is a slight decrement, but not to the effect, not to the in other words, not to the extent that impacts any of daily activities. So you have measured and evaluated this child, and you know what to expect in terms of vision performance. When wearing these lenses, you're ready to fit this child into a myopia management spectacle lens. There appears to be no specific or no additional requirements to fitting a child into these lenses. You just have to ensure that it is fitted to the center so that they can see through that clear central portion, or it is aimed for distance refractive error. You might have to pay attention to the frame size. Generally, the preference is to try and fit the largest frame size possible so that they get the benefit of the treatment zone. And also be mindful of the nose bridge, just in case the frame is to slip much more on that child given to other children. You should keep in mind that when we talk about the efficacy of these lenses, that these lenses, most of the myopia management spectacle lenses were assessed in clinical trials where the astigmatism is limited. So we do not know how these lenses might function in a child with very high amounts of astigmatism or those with very high amounts of myopia. So you have evaluated the child, you know about how these lenses perform, the visual performance of these lenses, and you fitted a child and you now have to follow up the child. How frequently you follow up the child depends on number of factors: the age of the child, any history with respect to past progression, as well as the comfort level of the child as well as the parents. But generally, anyway, from 3 to 6 months when the children are younger, and if they're seeing you for the first time, and then you monitor them at less frequent intervals as you continue. So with respect to monitoring, again, you follow the same techniques as before, which is trying to look at the refractive error, and where possible, also monitoring progression with an axial length measurement if you have access to an axial length. So when you're monitoring these children, you find that some children have not responded to the treatment strategy as you expected them to, or they're continuing to progress fast. So what is it that you can do? The first thing I would say is to check on compliance, because there have been a number of studies, multiple studies, both across spectacle lenses, myopia control specs, as well as myopia control contact lenses, that have shown that improved compliance means better efficacy. So might be worthwhile to go back and ask the child and or their parents as to whether the child was wearing the lens for all waking hours, from morning till evening. So better off asking them how many hours a day does the child wear these lenses, and also how many days per week, because in some instances children might be taking a break, especially in certain countries there's a concept of taking a break from these strategies over the weekend. So you might be better off asking them these questions and try and encourage compliance. If they doing per instructions, and if the eye is still progressing, then it might be, and if you've seen that this has happened over 2 successive visits, then it might be time for you to consider mixing up the strategy or changing the strategy. If it is not working with monotherapy, the single strategy, then it might be time to consider combination strategy. Here, the information with respect to spectacle lenses, it's only becoming available now. But what I also wanted to bring to your attention is that the data seems mixed as to whether combination therapy is going to have a greater efficacy. Now, in this particular study, where they looked at axial length and spherical equivalent refractive error with single vision lenses, with a myopia control lens in combination with atropine, you see that there appears to be a decrease in progression with the use of pharmaceutical strategy in combination with the spectacle lens strategy. However, what we do not know is whether this child would have had the benefit just with the use of atropine alone. So that this needs to be taken into consideration, because dual therapy, combination therapy is not that simple, because the parent will have to consider 2 different types of treatment. And if things do not go to plan, you have to be sure as to why you're not getting the effect. Is it, for example, atropine that is not giving us the required benefit, or is it the spectacle lens? So consider dual therapy quite carefully, and reserve it only to those eyes where you do not see the expected benefit. I wouldn't suggest that this be considered as the first line therapy. So in summary, myopia management is fast becoming the standard of care, and something I would advise you to consider, because there is substantial evidence that shows that we can slow the progression of myopia with not only spectacle lenses, but also contact lenses, as well as pharmaceutical strategies. Choose a strategy that fits the child, and especially if the child is in that age-sensitive period. We know that younger children progress much faster. Then it is very important that you get them into a myopia control option as soon as possible. When you're considering the refractive error of the eye, especially in young children, please remember that there is a significant difference between non-cycloplegic and cycloplegic refraction. So when you're measuring and evaluating this child, do consider cycloplegic refraction where possible. Try and maximize outcomes for a given child if they do not seem to be responding to the strategy, either by improving or considering wearing time or by considering, for example, combination therapy. With that, I'd like to finish and thank you very much for your attention.
Thank you everyone for your attention. Sorry for this little quack. It's always quite difficult to have a video during the webinar. As I was saying during the introduction, we are very, very happy at ZEISS now to welcome Padmaya. She is head of myopia department at ZEISS at Vision Care, and she's also head of a board. We have now 12 specialists in myopia talking about everything about myopia management. So they are in charge of new lenses, of clinical trials, of everything. So I just want you to understand, but I think that it's already the case, that ZEISS is not having only for once myocare lenses. This is something which is really important to us, and we're putting a lot of research and very important people into it to find solutions to slow down the pandemic. So this is the first point. Second point, I know you already know a lot about the ZEISS myocare lenses. Just to sum up, this lens is already available in UAE. We have two different types. One which is a hard design that we prescribe for children up to 9 years old, and we have the soft design from children from 10 years old. Okay. If you have any questions about ZEISS myocare, please just write them on them, but at least I will try. And if I cannot, I will contact her and get back to you with better answers. So thank you again for Padmaya.
Thank you so much, Celine. Moving forward, let me welcome our third speaker, Dr. Millicent Green. She is a specialist ophthalmologist with over 35 plus years of experience and an owner of Gulf Eye Clinic, Dubai. She is going to highlight us on other myopia management solutions. Welcome, Dr. Green.
I need to, okay. Good evening. Good evening, everybody. Thank you for this opportunity to share with you a bit more on the other myopia management solutions. So the first part of my talk covers what has been covered before, so I will click through that quickly. So this is what we want to do, is myopia management. And the reason is that we need to do our best to have patients progress from having normal retina and function to an extreme situation of degenerative myopia. There's so many times been said that the earlier it starts, the worse it can go. And therefore, our role is both from optometry side and ophthalmology side to be proactive and do what we can. Thank you for the two speakers who preceded me. Very insightful. I gained a lot and they covered quite a lot of ground. So why do we do myopia control? I think that has been very well covered. I'm going to cover a few other aspects as well. So I think this I don't have to repeat. We know that in some, for instance, Japanese study, at least 12% from vision impairment was caused by pathologic myopia. So that would be the kind of patients that I would take care of when myopia has unfortunately run its course. Myopic macular degeneration has also been reported to be a major cause of monocular blindness in Taijimi, Japan, and the leading cause of new cases of blindness in China, and it won't be in the only city in China. So studies, recent studies were done and published that basically see what had happened in recent years, comparing patients from pre-pandemic studies and then just seeing in 1 year in the pandemic how much change has happened and how the myopia ended up being influenced significantly. We see that in young children where the prevalence of myopia just doubled and significantly. So why, again, the 4 important points that happen when patients become highly myopic, that would be where it's not just moderate myopia, but severe myopia, would be the 4 diseases that we find exponentially increase would be glaucoma, cataracts, the presence of retinal tears leading to retinal detachment, and then, of course, myopic maculopathy or myopic macular degeneration. This is more prevalent in all higher myopes, as we have seen and heard before as well. So the risk factors, again, mentioned parental myopia, the age of onset, ethnicity is a fact that we need to live with, low outdoor activity, near work. It is also prevalent in high levels of education. At some point, the assertion was made that, yes, we study and progress intellectually, and oftentimes is at the price of our eyes. Female gender seems to also be a bit more prone. So there we have the family, generational, generation by generation, we see in studies that were performed that myopia just increases. And then the genetic situation exists, and then there is this complex interaction between the genes and then, of course, the environmental situation and behavior. This is not an unfamiliar picture. Is that really fair on the kids to make screens available? We all go to restaurants and we see that the kids are being kept busy. They take their iPads with them. The urban environment in general, people who live rurally generally are known to be more hyperopic relative to those living in cities. Are we doing our kids any favors in the modern digital world? I think we've seen now that instead of being modern, we sacrifice our kids' eyes as well as mental well-being. That's a totally different topic that will be addressed elsewhere. And then also the dependence on devices. I think we know in our own lives that devices take over a big portion of our lives, and the mental health results as well. So it's not just in terms of myopia, it goes much further than that. Yes, so pathologic myopia, what happens when we have the eyeball growing? There is, among other things that happen, choroidal thinning, therefore reduced blood flow in that essential part around the macula, in the retina, and hypoxia, and eventually loss of function. And here is a little illustration of what can gradually develop in myopic maculopathy, where the central vision goes. The middle picture tries to illustrate retinal detachment, where we have a significant loss of visual field as a symptom that shows up. So the 3 aims that we have all as practitioners is to screen patients with risk factors for progression, to stabilize the myopic progression as it already kicked in and is a reality, and then obviously to provide the optical correction for a healthy visual development. we have the options for control, and this has been well covered already. Lifestyle is so important in this day and age. Glasses, of course, and the various iterations of that. Contact lenses, different iterations, and then, of course, pharmaceutical. The best control is obviously to detect this early. Kids need early childhood eye exams. The routine exams are important, even if they don't seem, a patient doesn't seem to have vision problems, because they don't necessarily know to say what they see or don't see. So routine exams, the parents and our patients need to be educated to know that this is important. So for babies, the pediatricians and general practitioners who tend to see them need to have this as part of their awareness. Preschool kids between 3 and 5, where you pick up quite a lot of binocular vision issues that could retard their scholastic performance, need to be picked up in time as well. And those are opportunities for us to screen for risk factors that could lead to myopia. And then, of course, annual exams in the older kids. So this just says more or less the same thing, emphasizing again, binocular vision screen should be part of the screening protocol. So basically, this illustrates, it's like a summary version, where environment remains important. The treatments that are available need to be optimized. There are newer innovative means available. We want to make sure that is valid for each patient and make that available. And then, of course, don't forget, like was said before, the binocular vision. We tend to not attend to that well enough. So again, we have the different optical options. And then in contact lenses, I'll go and explain that a bit more now. So what do we need to achieve when frames are used? There is a particular goal with contact lenses. What do we want to achieve? Non-optical means, what do we want to achieve? So if you go back to the theory and the understanding of how our vision works, we see that in single vision corrections, the optical, let's say the optical dome in the back of the eye is not adequately formed in the usual and older style traditional optical corrections. And what we want to improve on that, obviously, is the different variations of multifocal glasses as well as contact lenses. So orthokeratology is one of the contact lens options available, and also known as Ortho-K. This is a version of correction for contact lenses, hard contact lenses, with a long history, starting among adults for the convenience of daytime freedom, so that you sleep overnight, you have a mold changing the shape of your cornea, and in daytime you have freedom. There is a bit of loss of effect during the day, so therefore, like a retainer, you need to use these lenses every night to get the desired effect. So in a recent couple of decades, the understanding came about that for teenagers, where these lenses were used as well for the sake of sport and lifestyle, that their myopia tended to slow down. And after quite some several observational studies through the years, let's say around the turn of the century, the understanding came that yes, Ortho-K is a valid means to assist our teenagers in their myopia progression, as well as the control and the limitation of the complications of myopia that may come when it is uncontrolled and just progressing unattended. So this Ortho-K uses RGP lenses in a specific design. It has molds that are worn overnight. there's a temporary change on the shape of the cornea, so that vision is clear the next day. It causes the peripheral myopic defocus that we need and reduce, therefore, the peripheral hyperopic blur. And it has been recorded, and it is now known as a means to limit the elongation of the eye. So how does it work? So a normal cornea before the lens has this ortho-K mold. It's basically a hard contact lens of which the inner surface is not also round. It's actually a little flattened for the needs of the patient. So when the ortho-K mold or lens is put on, a patient can immediately see well because it is designed for their refractive correction. And then after a period of sleeping with the lens, there is a gentle molding that happens, mostly on the epithelial layer. There's very little stromal molding that happens. And the result of that is a relative flattening in the middle. One can imagine that overnight, with the normal movement of the epithelial layer, that epithelium will gradually fill in that little space beside the center, pericentrally, and that brings about the shape change that we need. And that shape change then has stronger focal effects around the center, and that would then be what pulls the hyperopic focus in and helping us to have the myopic defocus effect. So this is what it looks like. Good treatment of orthokeratology on the upper two. It's two way different studies that I got the pictures from. And it doesn't look that much different from LASIK patient's eyes. At the bottom is a post-LASIK. The difference here is you can see the LASIK is very nicely centered, whereas ortho-K sometimes is a tiny bit off-center. Desirable is that we get it very nicely centered for a good regular effect. And but the what you achieve is temporary and similar to LASIK, in the sense that in LASIK we remove tissue to achieve a flattening of the central cornea, to achieve the focus shift for the clarity of vision. This is done in adults and beyond 18 years of age, and where myopia is already stabilized. So there's rules that need to be followed the same for surgical correction as what it is here for the temporary optical correction in orthokeratology. So I think this is a repetition slide. So this is a lenses that are used is a proprietary designed fitting sets. That's one version. And these usually help up until, say, -4 with, say, cylinder 1.5 or so. And that is unfortunately limiting the scope, because you all have seen young patients with corrections higher than that. So that is why it is good to know that there are customized designs available as well, which provide a wider scope, both in sphere and cylinder, for correction. So we can actually help patients, children, adults, all who have larger than -4 correction and also higher cylinder corrections. We've, in our practice, sometimes been pleasantly surprised with what looks like a tough correction that actually turns out really nice, because it is a customized design available to us. So this specialized contact lens gets used overnight. The material has high oxygen transmission. It is inserted filled with saline, so the mold rests on your tear layer, not directly on the epithelium. And during sleep time, there's no blinking. So the lens does not move like ordinary hard contact lenses during daytime when you blink and the lens moves on your eye. That does not happen. The eyeball, yes, moves under the lid. And during that normal sleep time movement, the lens sits in its place. It has created a seat, and there's a gentle molding that happens during your sleep time. So, like I said before, over time, ortho-K therapy has been found, and we have seen in our practice that it does reduce the elongation of the eye. So then let's move on to the next pharmacological option is atropine drops. So atropine, as we know, is one of the muscarine blockers, and it relaxes the focusing muscles inside the eye. Initially, atropine's use was in cases of inflammation like uveitis, and so also diagnosing strabismus and latent hypermetropia. I remember earlier in my career, you used atropine to do cycloplegic refraction, had a long period of recovery. Fortunately, we have newer drops available that doesn't have that long effect, but that was the initial use of atropine. And so now it's found to be useful for slowing down myopia progression. The initial hypothesis there was that eye fatigue was a factor in myopia, but later studies found that atropine has wider effect even on receptors in the retina. So it is important to remember that there's the bit of pupil dilatation that you can get cause light intolerance for some patients. There are patients who are allergic to these light shade origin. It's from the belladonna plant, and that's part of light shades. And some patients are allergic to that. And muscarinic effects can be systemic as well, and that may limit the benefit that patients can get from the use of atropine. It's very important that when atropine is used, that there is regular monitoring of axial length, so that if it proves not to be efficient, that the myopia control scope and options that are used is expanded. And so that we're not just dependent on atropine as an option for myopia control. So there are benefits and drawbacks. So I've said before, I showed different concentrations, 0.01, 0.02, and now 0.05. So the time of optimal time of effect of using atropine drops has in some research been said to be 3 years. There is a large benefit if it is used in the peak years of the myopia progression, and our earlier lectures have explained how that works and what the ages are that are important. It is important to know that when atropine is impractical to use, such as when there's allergy, light sensitivity, also when it's not used regularly, there is a possibility of a rebound effect, even with a low dose atropine. And that can mean that the myopia progression can speed up again when you've had to stop. Even availability in some countries, it's not easy to get it on the market. So if you've used atropine for a while, you are forced to stop it, there is that chance that your myopia progression could rebound. So the amount of myopia rebound and the number of children who experience that may be small, but it is important because you want to make sure that the patient is not unnecessarily disadvantaged in his myopia journey. So if we look at the different options of myopia control, with the multifocal soft contact lenses with a center distance, which is the preferred way in soft contact lenses, yes, the patient doesn't have the need to use frames during the day. A bit of a limitation is water-based sport and leisure. So patient may therefore have to use the combination of soft lenses, not to have frames, but when in water activities, as they will need to revert back to say glasses and the like. So the same with bifocal and multifocal and myo control glasses. It is true that there's no foreign body in the eye. You can use this when there's contact lens intolerance, for instance, but it is important to use the glasses full time so that you will see for one, but also to have the actual benefit of that. Atropine, yes, it provides the control, but you are still dependent on devices to see. So you still have to use your glasses to see. The atropine is just a help for the limitation of the elongation of the eyeball. In orthokeratology, one can have the benefit of control, but also a nice bonus in the sense of daytime freedom from devices, glasses, and or contact lenses, because the change, albeit temporarily, is done in the cornea during the night. And because you lose a bit of effect during daytime, you need to reinforce, and therefore it's like a retainer that you use overnight. So it is also important to take care of patients' lubrication needs, make sure the eyes are not too dry and make them intolerant of these molds and lenses, and how they remove that, how they insert that, so that the care is conducive to continued use and continued benefit of orthokeratology. So there are a few, I said here, myths and facts that we want to see if we can enlighten on that, or you can say reservations to the use of all these different options. It's important that we have the knowledge, that we educate our patients, that we educate ourselves, of course, so that we can confidently guide our patients for their needs. So why would one sleep with contact lenses? I think a few years, we know we allowed patients to sleep for a full month in extended wear soft contact lenses, and we didn't think too much of that because it was convenient, and we know that a lot of those patients actually swam in those lenses and made us rather concerned about it. But it's not a new thing to sleep with contact lenses. However, here with the lenses such as orthokeratology, you are at home, your eyes are closed, you have a cleaning system that is the cleanest among all contact lenses with hydrogen peroxide as a preferred way of cleaning. And we make sure that we train our patients as well as the parents of our children, patients, to ensure safety. So those who are well trained are empowered to deal and use their corrective means safely. So what about damaging future options in vision correction? We remember in hard contact lenses before, if we want to do laser vision correction, we've had to ask patients to please get out of your hard contact lenses, maybe move into soft lenses for at least 2 or 3 months to get the effect of that molding to go away and show up the natural shape of the cornea. And then, of course, in the last few weeks, we had to say, please get off of your soft contact lenses because of the potential warpage that needs to undo itself before you can consider the patient's eyes being suitable or not for laser vision correction. So if you manage this very well and wisely, you don't really limit future options. And also, of course, make sure that there's no allergic intolerance that become evident along the way. So we want to keep the correction of our myopic patients in manageable proportions for the sake of, we know that laser vision correction with very high myopia is actually impossible because it's not usually enough cornea available. So the quicker we can start to limit the progression of myopia, the better chance the patient has as an adult when everything is stabilized and they want a vision correction option. They have the scope in their corneas in terms of the available amount of tissue to get the correction and to actually regain visual freedom later on. So then the next question is, children, are they not too young for contact lenses? We need to give them what they need. We need to educate and train and make sure the parental support is well done, is available, and we take care of issues that arise. And it's wonderful actually in our practice to see the motivated patients of parents of very young patients who really want to let their child not go through their own -6 and 7 and catch it early, and how motivated they are to learn and end up supporting their children to limit the amount of clearly genetic myopia that's present. So is there any proof of benefit of all of these options? When it's not well managed, then it's hard to really get the benefit to happen. So just the same as in ordinary glasses, we know if you don't use your glasses, you will also have accelerated myopia. Those who are using orthokeratology, when they skip nights too regularly, they reduce the benefit. They don't get full molding, and they basically can slip back into low levels of myopia by the end of the day. And that is why we need to monitor them regularly, need to make sure that the effect remains desirable, and encourage them to be very regular so that they can achieve the amount of myopia control that they need. And still important, dry eyes can scupper a lot of what we want to do in the sense of intolerance of hard lenses or the molds, intolerance of soft contact lenses. So it's very important that those background difficulties are taken care of. We see young children whose meibomian glands are really so suboptimal that we have to get that managed as well, so that the lubricant qualities of our tears and of their tears are available, so that they have comfortable contact lens wear and therefore comfortable control of their myopic condition. So what about expenses? So yes, these are all proprietary new designs, and lots of R&D went into this, and therefore it is not necessarily financially easy for quite a large part of the myopic population, but where we can, we see that it's also expensive to do annual contact lens costs, as well as breakage of glasses. So there is a cost to any of these options that we use, but it's a treatment that we do. Myopia is a condition that needs monitoring, that needs control, and we need to do what we can and do that as efficiently as we can. The question about why will you sleep with foreign objects, I think we said before, we did that with extended wear contact lenses. So it is a matter of education. Make sure the environment is controlled, is clean, that there's no unnecessary dust or allergens. Any person with daytime contact lenses are actually exposed to the environment and all the pollution and more. So then to negate infection risk, the rules are so much the same as with soft contact lenses. If we have to be careful, the rules and the training that we give our patients in using contact lenses remains important to follow and to do. So the hydrogen peroxide % solutions, as we know, is your cleanest way of cleaning any contact lenses, and that is our preferred way to have our patients clean their lenses. So that part is good and well covered, but then also training, regular review, and assistance in the skills of insertion and removal. Train the parents to do their troubleshooting so that their support can be optimal, and make sure that our patients can benefit from the treatment that we want to give. And then what about the limitations of corrections? There are several, probably 8 or 10 or more proprietary fitting sets all over the markets for orthokeratology use. Those are usually in the, say, low to low moderate myopia range, up to, say, -4, with not more than, say, 1.5 or so astigmatism. And then there are also the customized designs, which we happen to use, which basically expands and the range of corrective treatment that we can give our patients. So we need to be aware and again educate our patients, pick up on trouble, regular reviews, and that would be the likes of red eyes, of blurry vision, and anything that causes a suboptimal visual result and clarity of vision. For instance, patients' binocular vision needs to be taken care of beforehand. Amblyopia and the like needs to be taken care of beforehand. Otherwise, the fuzzy vision that you might encounter, is that due to amblyopia or is it due to the lens being suboptimal? So it's a comprehensive care that we give from the optometry side, and then of course from the ophthalmological side, that we take care of all the background difficulties when we embark on these myopia control treatments. How long will it be needed? We know that a lot of patients and teenagers will have this rapid teenage movement, and then thankfully by the end of their school career they tend to stabilize. But there's also a significant portion of our population that will only stabilize in their mid-20s. So I tell patients that this started among adults who had no let's say myopia control concern for the convenience of treatment. So that means that once you're past this developmental stage of needing to do myopia control, you can continue to use it for as long as you want. And when there are issues that make it difficult for you to use, then once you are a stabilized, myopia stabilized adult, you can of course look at other vision, more permanent vision correction possibilities. So does this fix myopia? That's often a question that comes. Yeah, as we know, unfortunately not. Myopia has kicked in, the actual length is there, or the keratometry is relatively high. We have all seen shorter eyeballs with high K values that are also myopic, and that's a structural thing. That's not going to undo itself. Sorry for the spelling there. We need to also, of course, take care of irregular shapes. For practitioners who do not have access to topography, they can give glasses and for optical corrections, and it's suboptimal for the patient. And when we do have the chance of assisting these practitioners, often the topography reveals a irregular astigmatism, and that can be anything from say a very early keratoconus versus frank keratoconus, but also let's say variations of that, such as pellucid changes, which can give a fairly regular mid-astigmatic treatment, but actually show up a weak cornea. And those are patients that we need to rule out because you don't want to manipulate the shape of the cornea when it's already adverse. Then it's a totally different treatment that needs to be taken care of. It's important to understand that orthokeratology done well is a controlled environment, and therefore for use of the molds and the contact lenses. And when it's done well, the benefits will be there. And like we said before, we are all after limiting the progression of myopia. We have seen, and you have read studies where the two better ways of controlling myopia progression is atropine and orthokeratology. Each have obviously its drawbacks and benefits. And then when that is not possible, then we now have the additional help from the special glasses, MyoSmart and the like, and glasses, and of course the soft contact lenses with the multifocal center distance. So now last week we saw a publication put out by Dr. Kate Gifford in Australia, and she's a person definitely worth listening to. So she went and put out the article that is literally hot off the press. It's rather interesting. I'm just so that you will hear more about it in time to come. So let's just have a little overview here. So this is repeated low light, no level red light therapy. She was looking at safety and efficacy. It's a whole new buzzword that will probably show up with time. So there's looking at the efficacy, at the axial length stability, shortening, the safety of use of this in children, and then like a summary. So the exact mechanism at molecular and cellular level and the influence on the ocular structures is yet to be determined. In China, where this has been used before as a treatment for amblyopia, there were then unpublished reports of potential benefits where somehow it increased the choroidal thickness, therefore there was improved blood flow, and notably then stabilization of axial elongation. So that was catching the attention, and the thoughts came to mind, hey, what about this situation in myopia? So the mechanism, it is thought that it can address the myopic structural changes at the retina and choroidal level, and why, which then reduces this scleral hypoxia, and then reducing the risk of development of progressive myopia. So what is the future of that? Like atropine, it's a non-optical intervention or adjunctive treatment. And there is the possibility of even combining that with other treatments or to have it as a monotherapy. So the efficacy of the RL treatment for myopia control in the first published multi-center Chinese trials, the children 8 to 13-year-old with cell up to 2.5 were included in this trial with a bit of anisometropia. The protocol for this device is to be used. It's 180 seconds. Parents must supervise. It gets done twice a day, at least 4 hours apart, and for 5 of the 7 days of the week. So what was found is that in terms of axial length and shortening and rebound, that with stability, the 1-year data found a treatment effect of less refractive change, 60% less refractive change, and less axial length progression, respectively, compared to the control group that either had no or very low levels of the same treatment. So the 2-year data then found that both in refractive changes as axial length, there was up to a 75 slowdown in the progression of myopia. Axial shortening effect, the retrospective clinical data from kids 3 to 17 years with at least 1 year of treatment showed that 26, 17.5, and 4.6 with axial length measurement reduced respectively 0.05, 0.1, and 0.2. And then there was talk about rebound effect. So in the second year of this multi-center trial, 52 kids stopped treatment, and they then showed this amount of mean axial length in that following year. And compared to a significantly lower axial length growth in the no treatment group, which means that was sound the bells for rebound. So the authors, they noted that these children were young at the time that they stopped the treatment, and therefore continuation may have actually benefited them. So what is the safety in children? So this is just a bit of technical how the device actually works and what amount of energy that it uses. And then, and it's needs to obviously comply with regulations in terms of emission of the red light. So there are a few reports of adverse effects, and in the published study, one 12-year-old young lady had a bilateral vision loss after using it, but recovered to 20/25 after 3 months. Then there 4 other events happened as well, similar symptoms and signs, with prolonged after images is what they find, lasting more than 5 minutes after the use. And they also had a reduction in best-corrected visual acuity, and then they could see on OCT evidence of the changes. So all these reported full recovery of acuity, as well as the OCT image changes after cessation of the treatment. So when they had these changes, they just stopped their treatment. So in the data supplied, that's how many users there are. And so it is a rather low percentage of those cases that were published. So then the possibilities of this has, or the, let's say, the adverse effect that has to be studied and making sure about the safety has to do with the light power stability, extended exposure, and so on. So the device and the designers and suppliers work on making it a stringent protocol, so that there's no unnecessary use and the machine won't work before 4 hours again, and so on, to make sure that the safety factors are taken care of. So as a promising approach for myopia control, seem to be a growing body of research becoming available. So most of the studies obviously happened in China, where the device was first used, but more studies are now happening in Australia, Japan, US, UK, and also in Singapore. So the questions of how does it work, how do you manage the cessation and avoid the rebound, and how it could combine with optical treatments will obviously bring a new wave of knowledge for this particular treatment. This is just an infographic trying to summarize what is it that we are busy with, what's the risk factors, how do we manage that, know which are the increased risk of progression, what do we do to reduce, and of course review very well, follow up our patients, and close follow review. So we just wanted to do a little alert. We plan a question and answer session soon, now in December, for those around us. So just have a look at that. I think we have published this on some of the media. So we hope to assist and provide answers for your questions as you may need. Okay, so thank you very much for your attention, and I hope this was useful for you all.
Thank you so much, Dr. Green, for your wonderful insights on different solutions for myopia management. I would like to thank all the speakers for their valuable time and for sharing your knowledge to all of us. Moving forward, let me welcome Dr. Yazan, Dr. Green, and Ms. Saleen for the panel discussion.
So great. Thanks a lot to all the speakers. It's a wonderful presentation for everyone. Hope everybody agreed. Big round of applause for all the speakers, even the virtually presented and Dr. Padwaj also. So we can start our panel discussion today with the first question to Dr. Yazan.
Yes.
How important it is the adapting the examination room for children assessment, and what are the factors or criteria you will keep in mind, Dr. Yazan? Over to you.
It's quite important actually to adapt your examination room to assess PEDS. Remember, children are raised to be scared of doctors. You know, this is our fault as parents. So you need to make it as friendly as possible in terms of the colors, the furniture, also the equipment itself. You need an LED-based visual acuity chart that has pediatric charts, or you can use the portable LIA-based system, for example. You need to have the chair at the level of the children, allow the parents to be as close to them as possible. And you need to have a pediatric trial frame. Remember, their PDs are much smaller than the regular adults. So every little detail matter, actually. So, yep, basic question for anyone who
May I
works with children.
just say something that might be interesting?
Yes.
I
Yep.
just come back from China, and I had the pleasure to visit many myopia clinic over there, and myopia optical store really dedicated to children with myopia. And there is one thing that I've seen, and I really do believe that it will be easy to do the same in the region. Either in an optical store or in a refraction room, they are adding a little corner where they put a desk, a children's desk, with a children's seat, and they show them the distance that they have, the behavior that they should have to slow down myopia. So not being too close to the book, they have to keep this distance. Every 20 minutes, they have to go outside for 5 minutes to get the light, and so on and so on. What I want to say is that in your practice, in your daily practice, having those in real life desk and items, even with children books and everything, is really going to teach them what they have to change in their behavior, and actually teach the parents what they have to look after. So just because that was a question, just wanted to share this. And it's not a lot of space, it's not a lot of time, and it's definitely having an impact with real points, real things and advices to follow to slow down myopia. Thank you.
I totally agree with you, Celine. I always say you should practice what you preach. So if you demonstrate it, the children and the parents, it will stick to their minds. Yes, well done.
So we'll take another question for Dr. Grimm. As we know, our eyes are in up and outward position during sleep, and ortho-K is a rigid lenses. So how it maintains its position in place and it's intact?
So when we start, the day that we dispense the lenses, they are put on the eyes, and we obviously make sure that, yes, they sit where they should. And then we have our patients sleep here in the clinic for 2 hours. And obviously to see, obviously make them read uncorrected what they see before you put the lenses on. When the lenses are on, it's, oh, I see, because they made for the need of the patient. And then, yes, they go to sleep. And after the 2 hours, the lenses come off. First we check, are they still centered? Yes. Then they come off. So during those first 2 hours, if they centered very well, it means they create a seat where the lens will go again that night. Then it's obviously training of the patient, training of the parent, all what they need to know for the safe use, the cleaning, insertion, removal. And now and then it takes a few sessions of training of insertion and removal before they get the hang of it, or before the parents get the hang of it, and then they can safely insert and remove. Then we let them go and do that night. We see them first thing in the morning with the lenses on, so that we can see the lenses sit well. They're still on. We then remove it. We see, all right, what's the effect on the corneal surface, epithelial surface? Is there anything that, like erosions or the like? So that, and then we make sure again about the technique. For me, it is super important to make sure that, that's my preference, that the lens is put in with you looking down, so that when you bring the lens to the eye on the little device, that it latches onto the cornea, and that you have that saline and tear film between the lens and your cornea. And then, of course, and then the patient closes the eyes, and yes, they know that something is there, but it's not annoying. So a good, well-designed lens won't be annoying. They can feel the lens, yes, but it's not annoying. So therefore, they go to sleep, and they get used to this effect. And very soon, it doesn't bug them anymore. So we make sure that we are happy that the lens sits well. It creates a seat for itself. We see after removal that, yes, they already scored a line of 2 on the chart just from the 2 hours sleep. And that obviously gives them the motivation and know, if 2 hours can give me this, how much will 6 or 8 hours give me? And of course, day by day, their molding improves. And then depending on their correction, after X amount of time, they will have their daytime full vision independence up until later in the day. So it's method, technique, training, make sure it works.
Thank you, Dr. Grimm. I have one question for Celine regarding MyoCare. So it is a question from the audience. How ZEISS MyoCare tackle with aberration at periphery of retina due to annular zones? Over to you, Celine.
That's a good question. So as Padmaya said before, the lens is having on the front surface a central zone with a normal correction, then a functional zone where you will have those scare elements, cylindrical annular refractive elements. So it's technically a positive power, which is going to create a hyperopic defocus on the periphery of the retina. Between each care elements, we will have, yes, the normal correction, because what we want is to maintain a good wearability, a great comfort between the efficiency of the hyperopic defocus and the good clarity of the vision. We also have on the back surface of the lens, and I like this question because it means a lot. If we only do the hyperopic defocus on the front surface, but if we do not minimize the aberrations on the back surface, the efficiency will not be that strong and not that fast. So we have a second technology on the back surface, which is going to minimize those aberrations. So even when rays are going to go through 2 care elements, so through the normal correction, thanks to this technology, they are not going to fall down after the retina, but be on the retina, even if it's in the peripheral part of the retina. The technology is named Clear Focus. Okay, it's on the back surface. It's really important, and this is only at ZEISS. So it's really a good question. Thank you for asking.
Nice explanation, Celine. As we have another question to you again. Somebody asking from the audience, dear ZEISS team, concerning the index of refraction in MyoCare, why did you pick 1.59 index, that is polycarbonate, I think, instead of 1.53, that is Trivex, since the optical quality will show a better performance due to the aberration, knowing that you have a 1.6 index, if considering the aesthetic part, thickness of the lenses? So what's
Saib, a very good question. What we have to understand in the world of optics is that there is technically a fight between those 4 polycarbonates and those fighting against polycarbonate, okay, the 1.59. The truth is that 1.59 is the safest lens for a child. That's the strongest one. So we had to do a compromise at first In terms of aberrations, we have those technologies which are really minimizing, okay, the hyperopic defocus, so we can manage that. But the first thing that we need to think of is safety. And when you have to wear glasses, it's already not fun, even when you're an adult, but when you're a child, running, practicing sports and everything, you don't want to take any risk about safety. So yes, 1.59 is a very controversial subject, but safety first, safety first. At first, we had only 1.59 available in both design, Myocare Hard and Myocare Soft. Now it's also available in 1.5 and 1.6 for Myocare normal hard design. It's also coming up in 1.67. So we are definitely not at the end of our portfolio about myopia management lenses in terms of index, coatings, and even design. It's coming up. It's coming up. Yeah, just need a little patience.
May I add
Thank you.
something,
Thank you, Celine.
please?
Yeah, please.
Let me be very honest with everyone and tell them that let's not really focus on NDCs. Let's focus on the technology, you know, how hard it is to develop such lenses. The technology and research behind them is quite remarkable. So let's think about the children and their visual needs and the myopia management at the end of the tunnel. And the details, as Celine said, the portfolio is growing up. And if you look at the research, 10 years ago, we almost had nothing. So thank you, ZEISS, for actually helping practitioners and having something that is accessible, you know, and cost-wise, I'm not going to talk about it, but as a practitioner, sometimes things get really prohibitive for me to prescribe something. It's that expensive. So yeah, let's focus on the positive aspects of management first. Then let's forget about the negatives for the time being. That's my
Thank you,
personal
Yazan.
opinion. Thank you.
Thank you, Dr. Yazan, and thank you, Celine. We'll take one more question from the audience for Dr. Green. What are the absolute contradictions for prescribing atropine? What we have to see before prescribing atropine and during the treatment?
So the contraindications for atropine would be allergy first. Make sure the patient is not allergic, and allergy. That would probably be the most important one to think about. It is also, like we said, a muscarine blocker. So be sure that the patient doesn't have other systemic reasons that will make a muscarine blocker a no-no.
I'll add something here, Dr. Green. Like in few studies in PubMed, I searched there. So it is showing that like longer like use of atropine, like long-standing use of atropine therapy may cause some connective tissue disorder for few children. So is it true? Like how your take on that actually?
I cannot hear very clearly the adverse effect. Sorry.
Yeah. So long-standing therapy like atropine therapy can cause some connective tissue disorders for the children's. So some studies show some study in the PubMed it's showing like that. So what's your take on that?
I don't at the moment have an opinion on that, to be honest.
Okay. Thank you, Dr. Graham.
Sure.
So we have one question for Dr. Yazan. So is it necessary to measure always the lag or lead of accommodation before starting the myopia treatment? Suppose someone like forget to do the MEM retinoscopy, or somebody like forget to take the measure the lead or lag. So what will be the effect on his treatment?
Well, I don't usually measure lag of accommodation every single time with every single child. But the idea is if you see any indications that should prompt you to do that, then why not? And remember, adding those extra 5 minutes for binocular vision assessment won't break the bank, as they say, and it will help you to get the bigger picture. So I would advise every single one of us to do that full BV assessment every time with children, and that's why your myopia management appointment shouldn't be 10 minutes, should be 45 minutes to an hour at least. So I know you might think that it won't generate your income for your practice, but you have to do it, unfortunately or fortunately. You have to spend that enough time and do all your due diligence as an optometrist. It won't break the bank. If you miss it once, it won't kill that patient, but please try your best. Okay?
Okay. Thank you, Dr. Yazan.
Yeah.
We're almost 9:10. Yeah, tell me.
Swarno, that question about atropine, can I say something about it,
Yeah,
about the
please,
side
please.
effects?
Yeah, sure.
If you think about it, some children might be able to tolerate. Some children have very low threshold to that blurriness in vision, even with the 0.01%. So you need to, not every child are the same, okay? So you need to think really carefully when you prescribe atropine with these patients. Sometimes they develop acute redness, so it's not just that allergy to atropine is the only thing we need to consider, just their tolerance to the threshold, contrast sensitivity issues as well. Can they tolerate that little bit reduction in visual acuity, or VA is good, even with that low dose? So just don't think of abstracts, black or white. No, think about the grayness in the response of the patients. That's my personal experience with these children. Okay.
Okay. Thank you, Dr. Yazan. I think you can close the panel as we're short of time, already 9:10. And we almost answer all the questions. Thank you, everyone. Thank you for joining the panel, and thanks once again. So here we'll be closing the webinar for this advanced level, second webinar. Our third webinar will be coming soon, maybe January end or February first week, maybe. So let's hope for the best. We'll meet again. And also our next big webinar is coming on World Optometry, that is Icon 2. That will be on 23rd March 2024. So you can register for this one also. And most important, that certificate that everybody is looking for CME certificate. So we'll be giving the certificate, issuing the certificate within 15 working days from today itself, because it takes some time to take the approval and everything. And hopefully you'll get the in the email, you'll get the form, and you need to submit the form, and then you'll get the certificate within 15 working days from today. Okay. Thank you, everyone. Thank you for joining, and thank you for listening. Good
Thank
night,
you for this
everyone.
opportunity. Appreciate that.
I just want to
Yeah.
say on the name of ZEISS, thank you for all of you who organized and worked very hard to share your knowledge. We really do appreciate your work, and it's so valuable, especially in the region where we do not have access to many options for myopia management. I just would like to say that we have an active LinkedIn group, which name is ZEISS Myopia Management, where those episodes of webinar links and marketing materials and everything are already shared and continuing to be shared. It's a private group, so please just request to get in, and it will be my pleasure to do so. The next episode will be, I believe, mid-January or end of January. It's going to be an expert level. In that case, we will share cases and try to see how to handle different cases, because as everyone just said, it's a treatment and reaction are not always the same, and protocol is not always the same depending on too many things. So I think that now all of you guys are ready to get real cases. Once again, thanks everyone. I just would like to ask, because I know that most of you attending this second webinar were already in the first one. As long as the chat is open, could you please share with us what you would like us to talk about? If there is any specific subject that you would like us to focus on, that maybe we can work after the expert level. Please feel free to share this with us, and as well with me on my LinkedIn as well. But I believe you already know me now so well. But please just share your opinion. Tell us what you thought about those episodes, about this second episode, and what do you want us to bring to you to help you to have myopia management. So my name is Céline Combrouse, and you can find me on LinkedIn with ZEISS. And please feel free to ask me everything about myopia as well. I know you are from many different countries. It's available in UAE, Lebanon. It's going to be available from January in Saudi, Kuwait as well, more and more region. Step by step. If you have any question, depending on your country, please reach out to me. And finally, we have some marketing materials that can be useful for you, some display, some patient leaflet, where we explain what is myopia, what it is important to treat myopia for a child, that LASIK is not only the answer, that all retinas damages are still there. So please just reach out to me if you need any support. Thanks, all of you. Thank you, Yazan, as usual. And yes, I don't think we can say a lot, Yazan, but what we can say is that beginning of January, we are working on a concrete project with Dr. Yazan about myopia management guidelines, and yes, we will share with you this information, but easy way to get to know what to do quickly, step by step. Next step, actually. Thank you, Dr. Grimm. Your presentation was definitely a high level. I could not understand everything, which means that it was really a high level. But thank you for sharing this, and thank you, Swana, and all the team.
Someone is asking, what is your LinkedIn group name?
It's a ZEISS, if I remember well, ZEISS, MyoCare. It's in the chat, Myopia Management. And you have everything on it.
Yeah. And for that attendee who is angry that I don't measure lack of accommodation in every single child, sometimes things do not work as planned with an appointment with the child. Sometimes they are tired, sometimes they cry. So I try to do the most I can, but that's why I always ask for a second appointment. So please don't punish me if I said that word. Things are not perfect in real life. And Dr. Millicent probably can testify to that, right, doctor?
Come again?
You can agree with me sometimes that life is not perfect, and not everything you intend to do with an appointment you can sometimes accomplish. That's why we always ask for other appointments, right?
Right. So one thing that I have learned in my career is that sometimes you have to become a child so that you can get through to the child. And it can be really silly moments, but you get the information that you need. Yeah, that's true. I noticed that there was a question about elaborating on multifocal soft contact lenses. I explained it in short terms to the parents that Me, a 60-pluser, will use a multifocal soft contact lens with the center as the reader and the periphery as the distance. In children, we do the opposite. We do the center for distance and the periphery is for near. And what we do is simulate on the contact lens a bit of what we achieve during orthocare or in an adult post-LASIK, that you make the center flatter and that ring consequently aids and helps hopefully to bring that defocus at the back inside the eye. So I hope this explains adequately.
Thank you, Dr. Grimm. Thanks, everyone. And thanks all the attendees, and especially thanks to UE attendees also. Like today is holidays, but instead of holidays, they spend this 2 hours webinar and they're still on. It's amazing, actually. Still, we have 200 plus
Thank
attendees.
you.
So thank you, everyone. Hope to see you soon in the next webinar that is expert level. Good night.
Yeah.
Good night, everyone. Thank you.
Take care.
Bye.
Enjoy.
Thank you,
Bye-bye.
everyone. Bye-bye.